My name is Natasha Williams, and I am an assistant professor in the Department of Population Health at NYU Langone Health. And I am a behavioral research scientist. I've been working in the area of behavioral sleep medicine for about 5 years now, and my work primarily focuses on addressing sleep disturbance among vulnerable populations and trying to understand some of the determinants of sleep disturbance and also effective interventions when sleep disturbance is comorbid with physical and mental health illness.
What drew you to sleep in particular?
That's a great question. So a few years ago, I participated in the PRIDE training program, and PRIDE is a nationally funded program by NHLBI for underrepresented minority faculty. And I participated in the Cardiovascular Disease Summer Institute and met Jared and John Louis at that time. And I became very interested in his work. I was seeking mentorship at that time. I was thinking about a career change. And we continued to work together, and primarily as his trainee. And one of the first projects was to conduct focus groups among patients who participated in his obstructive sleep apnea trial. And in talking with those patients, that really drew me to sleep because of the underlying mental health and physical health issues that are often comorbid with sleep apnea, such as hypertension and depression. And I was really fascinated about the significance of sleep disturbance among this patient population.
So after your 5 years of looking at this disease in this population, where do you think we stand now compared to 5 years ago?
So I think I'll talk about it from the vantage point of health equity. And I think 5 years ago, there were very few studies that looked at sleep problems from the vantage point of vulnerable populations, particularly around race and ethnicity. And so over the past 5 years, I think that there has been a significant uptake in the amount of clinical trials that not only include minority populations, but report their results by race and ethnicity. And you see more of a presence in some of the national meetings around minority health issues and sleep. And that's a good thing. I think in that aspect, there's been a lot of changes and tremendous growth. So we're really raising the issue for not only funders, but researchers and clinicians as well. At the same time, there's still more work to be done because, for example, we really need to get to the point of understanding some of the mechanisms. So why is it that, consistently reported over 2 or 3 decades, African Americans report short sleep duration compared with their white counterparts? Why is it that African American men specifically report shorter sleep duration when you look at white males or compared to black women? So in that sense, there's still a lot of work to be done because we don't really understand some of those mechanisms. And secondly, I think the field or understanding disparities overall, if you look in the public health literature, for example, population health, there's a much greater appreciation of exploring determinants. And I think that's a direction in which the field should explore. Understanding...
Let me stop you. In English, what is determinants?
So I think for the field, it's important to understand sleep within the context of culture, sleep within the context of environment. How does one's occupation impact their sleep? The responsibilities of being a caregiver, for example. So all of those different social and cultural determinants are important, and I think those are some of the areas that we should really start to explore further.
Hold your thoughts 1 second. Would you mind like moving maybe 2 inches on the side? Do you need to change anything about the sound?
Let's just see where you.
Which lines up?
This way. That's it. Perfect.
That's perfect.
Yes.
Where are your notes, by the way? You don't have any notes?
Sorry?
That's you, the second person to ask me that.
His notes.
I've lived this life. You know how many of these I've done already?
Oh, goodness. I can only imagine.
This is typical of someone with ADD. He remembers everything.
I just told you. That's what 35 years of sleep apnea does.
Oh my goodness.
Same thing with me.
35 years.
I've been like, for 20 years, people say, where are your notes? I'm like, it's in here.
Really?
I'm a me. I write my. I have my shorthand and all
Right.
that, but I know what.
Oh, wow, that's really impressive. So 35 years
Okay.
of...
Since I was at least 2 years old, you know. It's scary, huh?
No, it's not scary. I mean, I think that obviously the importance of treatment when you think about that, but it's not scary. I don't know how you would, describe it as a patient, but
It was scary to me that I went through the system for so many years with access to every doctor that you could imagine, and blindly, because they weren't up to date, didn't know what they were looking at.
that's
That's
the challenge. That's the challenge.
Yeah.
It's challenging.
Adam, I'm sorry that I interrupted you. So you should get back to what you were going to
Yeah,
say.
I gotta figure out what I was gonna say.
Come on.
Why don't you go to those notes of yours? Huh?
One of these.
Smart asses
Good
like
business.
around
Yeah,
there.
everyone's a critic. Make me refresh my brain here. Where do we go here? 1 sec. So we talked about a little bit about what you see going on with health equity in your neck of the woods in New York. Do you feel like New York is a microcosm for the rest of the country, or more the exception right now with the work you guys are doing?
I think New York City is probably the exception. I think the diversity that's here in New York City, you will not find that in many parts of the country. I think it's definitely forward thinking in a lot of aspects when it comes to healthcare, when it comes to thinking about early childhood education, other sort of determinants of health, thinking about healthcare for incarcerated individuals. So in that sense, New York is definitely the exception, I think. And there's more access to treatment for sleep problems. We have public hospitals, for example, the New York City Health and Hospital Corporation, where individuals can get access to specialized treatment for sleep problems.
You got a question? I heard. So what would be the best advice that you'd give to someone who walks through your door the first day, as far as how to tackle their issues or manage their sleep or in everything else in life that they're trying to manage?
The most important advice, I think, is patients should feel empowered to discuss their sleep problems with their providers. Because it's often said that in sleep there's the don't ask, don't tell policy, right? When it comes to primary care providers. Primary care providers are less likely to ask their patients about their sleep problems, and we know why. At least there's some evidence to suggest why. But what would happen if a patient walked into their doctor's office and said, I want to talk about my high blood pressure, but I also want to talk about my sleep problems? I think there would be a very different conversation. I think the doctors would be forced to think about next steps, to think about solutions with their patients, and to figure out referrals. Is there a referral system in place for patients that have sleep problems? So we talk a lot about the role of the provider, and that's important. At the same time, at least my job is to educate patients about how sleep impacts their health overall and how they can start that conversation with their providers. We can't wait for the providers to do it. The patients can take charge.
You couldn't say that any better. This is a chronic disease that we have to live with. So 5 minutes inside an MD's office or with a nurse practitioner, whoever you're lucky enough to see,
Right.
is, this is something we live with every day. It's happening to us incrementally, whether we know it or not.
Absolutely.
Whether it's a sleep disorder or just poor
Right.
sleep habits or sleep
Yes.
hygiene, or if you're working shift work or whatever the case may be.
Right, yeah, and the providers will not, as I said, they'll be forced to come up with a solution in working with their patients. I don't think that if a patient started the conversation, I don't believe, it's possible of course, but I think it's less likely the provider would say, I'm not sure what to do with that. I think that they would make the initiative to work with their patients to figure it out.
Would you mind expanding on the potential, possible, or probable causes of why primary care physicians do not want to deal with this issue? Sorry.
No, that's fine. So there are a lot of things, right? So providers still may not see sleep as an important health condition. They may see it as more of a lifestyle issue. So if you are a low-income racial and ethnic minority, it's likely that you have multiple jobs. Or you're a shift worker. And in that case, it may be expected that there would be poor quality sleep or sleep disturbance. And so there's less likely to believe that there is an underlying health condition that could be playing a role in the sleep problems. Secondly, if you are working with a patient that has multiple chronic diseases, do you really want this patient now to deal with any kind of sleep problems that they're experiencing? So the care plan overall is complicated because this patient has diabetes, they have hypertension, they're overweight, and there's a possibility that they have sleep apnea.
This is where the education comes in. So regardless of whether you have one comorbidity, 2 or 3, especially the ones you listed, the metabolic, the cardiovascular,
Sure.
or the mental, regardless of whether there's a sleep apnea disorder, there's a sleep component
Exactly.
that until you've managed that, you can't manage the other 3 successfully.
Absolutely.
And that's
So there is, the CMS has this 90-day rule, right?
Yes,
that's for sleep apnea.
they do. Right.
Is it possible that the existence of this rule also pushes doctors to not prescribe like CPAPs and or?
So the providers, if you're speaking of a sleep clinic, they're mandated. They have to provide treatment. But if we're thinking about a small clinic in, Brooklyn, New York, for example, providers are working with patients that may not be adherent with their high blood pressure medications. So as a provider, I may be thinking to myself, what's the likelihood that this patient is going to be adherent to something like CPAP? And I could be well informed about sleep apnea, I could be well informed about treatment, and I know it requires a lot in terms of adherence. But I'm already dealing with patients that have poor adherence overall. This is a patient that I see every month, and we talk about diet. We talk about the importance of exercise, and those habits haven't changed as yet. And so I may be less likely to open that can of worms and talk about sleep apnea because of the complexities of adherence overall. So I think that there are several different issues at play in terms of providers having that conversation with their patients about sleep. And practically speaking, where would I refer these patients to? I don't know anything about sleep. That's not in my network of providers that I regularly refer patients to. So that's another challenge as well. So there are multiple challenges that providers are faced with.
Then some.
Right.
So, wow, there's a lot I want.
You're thinking about a lot of other follow-up questions?
Yeah, follow up with how to make this full circle. So, you're educating patients in the community to better improve their health equity or their health disparities. Because of the disparities, they're obviously already marginalized and below the
Sure.
proverbial Mendoza line, right?
Mm-hmm.
So, we've got a performance school issue, we have a tardiness, there's a lot of metrics out there that we can be looking at to where, you know, if we actually just focused on the sleep, or to come back to Jill's thing, I'm sort of wanted to answer this question for him. The CMS really put this 90-day rule in because anybody that walked into a sleep doctor had sleep apnea. This was their way of saying, wait a second, not everybody who has it has it. So it was because the system was abused is why this arbitrary law was thrown in. The 4-hour rule is literally 2 doctors having a glass of wine came up with that.
Right.
Which is totally
Right.
antiquated, prehistoric, because it's not even the first 4 hours you need this machine, it's the last 4 hours. So there are, it has gone back and forth, whether it's the clinician, the insurer, the regulator,
Right.
whoever, there's a reason we've gotten to this point.
Mm-hmm.
But what's scary to me as a patient and as a layman is that we have a treatable, curable disease. So imagine if your type 1 diabetes patient or your type 2 diabetes patient comes in and they're not adherent. What do you do then? You have the resources to bring in a diabetes educator.
Sure.
We don't have that yet.
Right.
And that's where that hole and that big gap is missing. If that sleep apnea patient, sleep deprived, cognitively deprived, someone held their hand in those first 7 days, first 14, whatever that arbitrary number is, the chances of them being adherent skyrocket.
Yeah, I mean, some of Jaredin's studies that he has in the field now involve health educators and working with patients so that they're adherent. And that's pretty novel because it's applying it to sleep apnea is novel. The model itself is not.
Exactly.
But it's brilliant because why not look to other chronic diseases and how they treat patients and apply that to sleep medicine?